Okay, let's get started to the final grand rounds of the academic season. It's kind of biblical here. The last shall be first, and blessed be him who stands and waits. And for this last grand rounds, I'm pleased to introduce two of my good friends who will be talking about treatments for gastric outlet obstruction, established and emerging. Our first speaker is Shayan Irani. Dr. Irani came to us from Temple University in Philadelphia. He was our first advanced endoscopy fellow, and he has stayed at Virginia Mason for the last dozen years and has established a superlative therapeutic endoscopy practice, as you will see today. Scott Helton is the director of our Liver, Pancreas, and Biliary Surgical Center and the Digestive Disease, as a Digestive Disease Center of Excellence. He's also section head of HPB surgery. He's had 160 peer-reviewed publications and past president of the AHPBA, the American Hepatopancreatico-Biliary Association, and just recently was awarded the Joel Baker Award for Teaching Excellence. So I'm excited. Tell us about these poor people with gastric outlet obstruction and what we can do about them.
Changing the lineup, I'm going to go first, and there's a reason for that. I think the reason I got picked to participate in this multidisciplinary talk is because the surgical management of gastric outlet obstruction is almost historical, as you're going to see, and I'm being one of the older guys in the department, probably one of the few people that remembers some of the old-time operations we did. So I'm going to speak first, and then I'm going to tee it up for Shayan, which is going to show a lot of the exciting stuff that has evolved over time. There's a single disclosure by Shayan for Boston Scientific. I have none. So briefly, I'm going to talk about the diagnosis and the overall management and tee it up to illustrate how treatment has rapidly evolved, swinging predominantly from surgery in the past to predominantly endoscopic now, but also to try to put in perspective the importance of surgery still and how this is truly a multidisciplinary team approach and why that's so important. So by definition, gastric outlet obstruction is associated or manifested by pain and abdominal distension. Abdominal distension can be quite subtle and just confined to the upper abdomen because there's nothing going beyond the stomach. Patients can actually have a scaphoid abdomen. Almost everybody has an element of vomiting, more commonly postprandial. And there has to be proof of mechanical obstruction. This can be anywhere along the stomach or in the first two portions of the duodenum. The epidemiology of gastric outlet obstruction is it can occur de novo from patient disease, which can be benign or malignant. The benign causes of gastric outlet obstruction were predominantly related to peptic ulcer disease, which is really diminished. And so in an institution like ours, almost all of the majority of the obstructions are malignant in nature or iatrogenic, caused by us surgeons and rescued by our endoscopists. Here's a long list of the benign causes of gastric outlet obstruction. You can group them into these categories as you see listed here. And then the malignant causes of gastric outlet obstruction. In an institution like ours, where we have a large patient population with hepatobiliary cancers, pancreatic, duodenal in nature, I'd say, I'm just going to guess, but more than 50-60% of our cases are probably pancreatic or duodenal in nature. but also metastatic cancers to the portohepatis, to the lymph nodes in that area, can result in obstruction. So the clinical symptoms are, as I said, pain, bloating, vomiting, early satiety. In patients that have benign, long-standing obstruction, weight loss is almost universal. These patients, when they finally present to the health system, are usually profoundly malnourished. The onset can be rapid and sudden, such as an iatrogenic situation where a patient might have a percutaneous endoscopic gastrostomy. Bouvray syndrome is a passage of a stone into the duodenum through a cholecystoduodenal fistula, and when that happens, it's quite brisk in onset. Patients can eke by slowly with a malignancy until finally there's complete obstruction, so it could be a very slow and insidious process. And it can just be indolent as nature. People tend to accommodate and get by putting themselves on a liquid diet, so they may have had obstruction for quite some time before even presenting, which leads to that chronic malnutrition. As I said, distended upper abdomen, scaphoid lower abdomen, and almost everybody has a succussion splash. For the youngsters in the audience, that entails putting a stethoscope on the abdomen and then shaking the abdomen. You listen up in the epigastrium, or actually in the left chest area, and you'll just hear this water bucket going back and forth. Sometimes it's audible, and you can actually hear it across the room. The differential diagnosis is really one entity, and that's gastroparesis, because the symptoms are exactly the same. The difference is there's just no mechanical obstruction. So when we work up these patients, we have to sort out, is this a motility issue or is this a mechanical obstructive issue? The diagnosis really comes down to investigation beyond physical exam and abdominal films, cross-sectional imaging, as Shayan likes to say, the favorite instrument in the emergency room. So I'd say the majority of the diagnoses in this day and age are made by CT scan because it's often the first test that's done. And then contrast imaging is very important and can clinch it because it can sort out, you can see whether or not there's motility, and you can actually see whether or not there's a mechanical obstruction. One can also diagnose it, of course, with endoscopy or fluoroscopy. I'll leave that to be discussed by Shayan. Here's an example of a plain film of a gastric outlet obstruction. You can see this silhouette of the stomach filled with air. Here's one in an upright position. You can visualize this is the stomach filled with fluid, and there's a big air fluid level. Here's a classic CT scan. Both axial and coronal images are useful. This is purely coincidental, but this is a patient that actually Shayan's going to treat this morning. That's a patient of mine that's post-operative, has gastric outlet obstruction. It's not necessary to have oral contrast. We prefer, in fact, just to use IV contrast initially. And here you can see how giant this stomach is, and it's so distended that the patient has reflux right up the esophagus because he's got an incompetent GE junction. Here's one of the advantages of the CT scan. In this particular patient, you can see there's something a little bit funky going on here at the outlet, and this patient has a tumor at the level of the pylorus. Here's another one of a patient who, here's a stomach filled with old food and stuff. It loops up around this way. You don't see it on this cut. But down in here, here's a little bit of haziness in the second portion of the duodenum. This is a dilated bile duct, and this patient has a periampullary carcinoma causing the obstruction in the dilated biliary tree. Here's a classic upper GI of a patient with a mechanical outlet obstruction, the so-called J-shaped stomach, and you can see a peptic stricture here. You don't know from looking at this radiograph whether or not this is due to a cancer or an ulcer. So basic management principles are patients should have a nasogastric tube, they should be resuscitated, they can be profoundly metabolically deranged. The classic presentation is hypokalemia, hypochloremia, and a contraction alkalosis. It's very common when you put a nasogastric tube, you'll get 2 or 3 liters out, and one should then replace the ongoing gastric losses, cc per cc, with normal saline and potassium chloride. All these patients should be on a proton pump inhibitor, and you should initiate nutritional support as soon as it's safe. When one does that, if you put a feeding tube in beyond the point of obstruction, it's very important to watch for refeeding syndrome because their gut really hasn't seen nutrition in quite some time. So the therapy for both malignant and benign gastric outlet obstruction are sort of listed here, and they are ideally, if there's pathology that can be resected, we want to resect it and reconstruct the GI tract. Sometimes we can't resect things, either because of the nature of the tumor, its location, or the presence of metastatic disease. It doesn't make any sense, and so surgical bypass would be the next option. As Shayan's going to show you, there are endoscopic approaches of doing this as opposed to surgery. Sometimes we can't even bypass a patient, and decompression may be not only palliative, but may be definitive if they have a short lifespan. This can be done with either a nasogastric tube, a percutaneous endoscopic tube, or an IR-placed G tube. If this is going to be done for a long-term palliative patient, then we really want to get rid of the nasogastric tube. It's so debilitating to patients, and so having a tube coming out through their abdominal wall is much more preferable. If one is doing that and you need to wait time for an operation or a definitive endoscopic procedure, always consider placing a distal feeding tube in all cases, again, to help resuscitate and replete patients. So the general approach to surgery is to decompress the stomach for a period of time before operating on them, because when the stomach is massively stretched out and distended, it loses its gastric tone, and it's going to be aperistaltic for a period of time. In the old days, we used to say operate no sooner than 7 days without a complete gastric rest to regain some of that gastric tone, to reduce the prolonged gastroparesis that occurs when we operate on these patients. Anesthesia, of course, has to be keenly aware and avoid aspiration and induction. You saw in that one individual, he's just got gastric contents coming all the way up to his larynx, super high risk for aspiration. Prophylactic antibiotics, in all cases, there's a high incidence of surgical site infection when we operate on these patients. Consider both a gastric tube for decompression postoperatively and a jejunal feeding tube, again, because it may be a couple weeks before the patient regains their gastric motility, and you need to decompress the stomach as well as provide nutrition. So let's talk a little bit about specific causes. Peptic ulcer disease. Medical therapy, as you know, has eliminated the majority of the need to operate on these patients. And this is still true today. When patients come in and have a gastric outlet obstruction and it's from a peptic ulcer, medical therapy still is the way to go initially, because many of these patients have their obstruction due to acute edema and inflammation, which is going to go away as the ulcer is treated. And endoscopy is a wonderful way to temporize in these patients, to open them up while they're undergoing that therapy. It's very key to look for and treat H. pylori. If you do not treat H. pylori patients and you operate, they have a notoriously poor outcome. So it's key to treat it and eradicate it. Patients should avoid smoking, and of course, in patients that develop ulcers disease on proton pumps, we need to make sure they don't have a gastrinoma. Consider operation when medical endoscopic therapy fails, and the question often that comes up is, well, how long do you wait to give one approach a chance to work? It's really dependent upon the patient and their underlying condition, and so you always have to individualize and tailor the approach to the given patient. And the type of operation one does for peptic ulcer disease is also very key on the patient's circumstances. I've just listed here the classic options for peptic ulcer gastric outlet obstruction: pyloroplasty, antrectomy, subtotal gastrectomy, and one can add a vagotomy. I personally have not done a truncal vagotomy in over 20 years. Proton pump inhibitors have essentially eliminated the need It would probably be considered malpractice to do a truncovagotomy today because medical therapy is so good and our understanding of H. pylori is so much better today. And if you do a truncovagotomy, it doesn't really help much, but it can lead to a lot of problems like post-vagotomy syndrome, diarrhea, and the like. The reconstruction can be done a variety of different ways, which I'll illustrate. There are also a lot of different ways in which a pyloroplasty can be done. Basically, one is just making a bypass around the scarred pylorus, as is illustrated in these things. So here's an antrectomy. This is for most of the internists so they understand what we're talking about. Removing the antrum, either for peptic ulcer disease or for a gastric tumor. And then you can just beyond the pylorus, the duodenum is stapled off. And then the downstream intestine is brought up and connected to the proximal stomach in a couple different ways. Probably the most common way today is what's called a loop gastrojejunostomy. So the antrum is missing and the stomach is just sewn side to side with a loop and then it goes downstream. Conversely, a reconstruction with a Roux and Y, this is more commonly used when we do a more larger gastric resection like a subtotal gastrectomy. It's easier to get the limb up there. The advantage of this over this is that one of the side effects here is you can, the bile that comes this way can go up into the stomach, and if you have gastroparesis and the stomach's not empty well, the patients can get reflux bile gastritis. Whereas in this operation, the bile is diverted downstream, and in fact, this is a great operation to avoid bile gastritis. But it can still happen, and here's an operation that was done in the 1800s by Braun. One can do this simple loop gastrojejunostomy, but downstream do a jejunal jejunostomy such that the bile short circuits this way and doesn't go up into the stomach. This is Shayan's least favorite approach surgically, since the endoscopist, when we ask them to go down to figure out things, sometimes they get lost there, but they've figured that out now. So let's move on to the management of malignant thing. This is, as I said at the beginning, by far the most common thing that we're faced with. The key issues to have a discussion with both the patient, their provider, and the gastroenterologist and the surgeon is to define what are the goals. These are both important from a short-term and a long-term perspective. Is it palliative or is it part of a curative plan? For example, maybe endoscopy is the way to go to deal with this obstruction, to temporize while the patient gets tuned up, maybe gets their chemotherapy and then moves on for a definitive operation later. So temporary versus long-term solutions, need to identify the appropriate approach for a given patient. Also think about their probability of long-term survival, because that can really be a stratifying point of what they get. We have to balance, like everything else, the risk and the success versus the morbidity of alternative approaches. So when we talk about, at the very beginning, patients with advanced cancer, surgery versus endoscopic therapy or palliation really depends upon many, many factors. The type of cancer they have, the location, the tumor burden, the patient's performance status. They may not tolerate either chemotherapy or even surgery, and so you really have to think what is the right thing for that given patient. And that should always be done in a multidisciplinary manner before charging down one pathway or the other. So how about for patients with really end-stage advanced cancer? We see so much of that here with pancreatic cancer, gastric cancer, etc. Again, establish goals of care. Here are the goals. We want patients who are at the end of their life to be comfortable. We want to avoid, if at all possible, a long-term nasogastric tube. It's so uncomfortable. It's no fun to send patients home with that. We want to relieve nausea and vomiting. It's a terrible thing for people that die of obstruction, having active vomiting. And we want to minimize hospitalization as well as rehospitalization for patients who have short survival. So ideally, if somebody has a cancer, you'd like to resect it and then just rehook them back up. But we really should only be doing that in patients with a good performance status and with an expected survival of greater than 4 months. We can do rescue operations, but in this day and age, it's rare that we ever have to because our endoscopists are so good, okay? And a general sort of theme is, in patients that have limited lifespan, 3 months, 4 months, try to avoid laparotomy if at all possible, because they're going to spend the majority of their time in the hospital. So this is a key concept. Okay, and so we should always initiate therapy on these patients with advanced disease from a minimally invasive perspective, and then go from there. If the minimally invasive approach works, then that's great, and that's an advantage to the patients. Another key concept is this thing called malignant gastroparesis. Many patients still have signs and symptoms of obstruction, nausea, vomiting, pain, distension, because they have gastroparesis. They don't have mechanical obstruction, but the tumor infiltrates the nerves and whatever, and motility of the stomach is messed up. So even with successful endoscopic and surgical therapy, these patients often still have these persistent symptoms, okay? So how about carcinomatosis? Again, we see a lot of that here, both in pancreatic and gastric cancer. Open surgery should be avoided because it's terribly ineffective. Less than 50% of patients undergoing an operation for obstruction who have carcinomatosis are never palliated. They will never eat again. They will not leave the hospital. They will have continued nausea and vomiting due to malignant gastroparesis. So the endoscopic approach is always preferable in them. And then finally, there are some patients that can't even be treated endoscopically. A G-tube, if you can get it there, percutaneously or with a PEG or under IR, plus octreotide, okay, is highly effective at palliating patients and getting them home. Multiple prospective randomized trials have shown the benefit of that approach. Here's just an example. Tumor, unresectable, let's say. This is what we used to do. We do a loop gastrojejunostomy. And this can be done laparoscopically and open. Interestingly, the cancer is the driver here in how long patients stay in the hospital and this malignant gastroparesis. There is no difference in the outcomes whether or not you do this operation laparoscopically versus open. It can be done through a very small incision open. But as you're going to soon see, this operation has been replaced now by an endoscopic approach. So how about the patient that we take to the operating room for a cancer like a pancreas cancer, and we get in there and now we find they have metastatic disease, but they don't have a gastric outlet? This has been an area of controversy. There are some that believe, well, you're there, so you might as well do a gastric bypass to them. And in fact, if the patient was fit enough to be going to the operating room for a potential giant operation, they're going to tolerate an operative gastric bypass. It adds very little to the morbidity. You're there, it's quick, it's simple, and it's very durable, as opposed to stenting that patient. However, if the patient does not have an outlet obstruction and you find peritoneal cancer, one should not do an operative bypass. And in fact, there have been recent large studies and even randomized trials comparing the endoscopic versus the operative approach. And this is something that was just published out of Tel Aviv. And I just show it because, I'm sorry, this is kind of blurry here, but if you look at the median survival, as pointed out by these red arrows, it's 100 days in patients that are either malnourished, if they have metastatic disease anywhere, and if they're over the age of 75, so that's kind of our patient demographic, they only live 100 days, okay, with a good operative bypass. So the problem is these patients are in the hospital forever. As I said, many of them never get out of the hospital. So the recommendation for advanced cancer, start always with a diagnostic laparoscopy, because if we find carcinomatosis, try and avoid an operative anastomosis, back off, go to the endoscopic approach or a decompressive procedure. Our goal is to get them out of the hospital to preserve their quality of life as much as possible. There's a famous study that was done at Memorial Sloan Kettering by my former junior partner, Joe Espot, where they looked at all their patients that had unresectable pancreatic cancer over about a 10-year period. And if they did not have obstruction at the time of their expiration, only 3% of those patients developed a gastric outlet obstruction before they died. So that just goes to show that prophylaxis is not really indicated or needed. And my last slide just says here are the multiple different types of complications that can occur after operation for gastric outlet obstruction. As I said, persistent nausea and vomiting because of gastroparesis, the post-gastrectomy syndromes, many of which can be treated endoscopically, and then failure to thrive and inadequate nutritional intake. So with that, I'm now going to turn it over to Shayan, who's going to illustrate how so many of the things that we've done operatively, the pendulum has swung to their domain.
Thanks, Scott. Good morning, everyone. So I decided to give this talk a different title. Oh no, there's a GOO. What shall we do? So let's go to the management of an admitted patient, which Scott's already covered about NPO, aspiration precautions for all these patients, and the role of PPIs. And there are two roles. One is to try and suppress the acid and secretory function of the stomach, but the other function is also to control the acid reflux, which some of these patients can report a horrendous amount of. Should every patient get an NG tube prior to an endoscopy? The answer is absolutely yes. Unless the INR is 5, please wait for that to come down before you put an NG down. Does an NG or a PEG guarantee an empty stomach prior to an endoscopy? The answer is no, but it significantly decompresses the stomach, reduces the risk of aspiration during induction at anesthesia. Scott's already gone over this management strategy. Figure out the underlying cause. Can you treat it? If it's malignant, can the surgeons resect it? And if it's benign, what are your options? Do you stretch it or do you bypass it? And then you want to try and prevent recurrences. So the conservative or the non-interventional approach applies to conditions that are reversible, such as pancreatitis. Some cases of peptic ulcer disease, like he alluded to, where PPIs can suppress the inflammation, and then hematomas will eventually resolve. So this is a case of a walled-off necrosis that developed about 3 months after a bout of pancreatitis. The patient represents with nausea, vomiting, and here's a fluid collection that's evolved around the pylorus, causing a gastric outlet obstruction. So you go in with an echo endoscope, get into the necrosis, put a lumen-opposing stent to drain that necrosis out, perform an ERCP, figure out where the leak is, which is over here in this case, put a stent to bridge that leak, and then temporize this in this situation with just a nasojejunal tube. And within 2 to 3 days, often the patient will resume eating and the nasojejunal tube can come out. So you don't have to do anything specific for the outlet obstruction. Let's see if this video plays. It does play. This is actually a very cute case of a man who presented rapidly with onset of nausea, vomiting. And this is a Bouveret syndrome. What you're seeing here is a large gallstone obstructed in the duodenum. And this is contrast being injected around the duodenum that's causing a gastric outlet obstruction. These are always fun cases. They are not short cases. They take a little while to break this stone up. And in this case, we're using a device called EHL to break this stone up. And depending on the size of this stone, this was about 4.5 to 5 centimeters. It took about an hour to break this stone through. And you can see a portion of the duodenum downstream now. So you keep working on this stone, breaking it piece by piece carefully, because there's usually deep ulcers associated with these stones. And then the other tool you have is you can throw a wire basket down. The tools you use in ERCP, grab these stones, break them up, and pull them out. And then eventually you want to make sure you didn't cause a perforation when you've done all of this. And then you can even inject and visualize the gallbladder, which you'll see over here. There's a catheter into the gallbladder, and what you're seeing here is the cystic duct. And you want to make sure there isn't malignancy as well, so you will often biopsy these things. So let's move on to dilation. The word bougie comes from the Algerian town where the first wax dilators were used or described. This was many, many years ago. Balloon dilation of the pylorus has been around since the 1980s. And these are the theoretical considerations when you're doing dilations. You want to open up the stricture by either a circumferential stretch, or you want to try and tear the scar tissue by splitting it. And then you want to try and keep it open. Bougies are not really used much in pyloric strictures or gastric outlet obstruction. This is what's typically used. It's a balloon. And this is the most common balloon we use. It's called a controlled radial expansion balloon, which often comes in 3 different sizes. So in one balloon itself, you can get the effect of 3 different sizes. This is what a peptic stricture looks like with fluid and food sitting in the stomach. This does not smell pleasant in the endoscopy suite. It's almost as bad as colonoscopy unprepped. This is what you do. You inflate a balloon in the pylorus. Usually do it under fluoroscopy to avoid a contralateral injury in the duodenum and a perforation. You try and hold the balloon up for 30 to 60 seconds, and this is what it looks like wide open about 2 to 3 months later. You usually go up in increments of about 3 to 4 millimeters or maybe 5 millimeters per session. You don't want to be too aggressive because that increases the risk of a perforation. The frequency of these dilations in studies is usually reported to be every 1 to 2 weeks. I think that becomes a little bit difficult for most patients to come back, so we allow 4 to 6 weeks, but you really don't want to push it beyond 8 weeks because the longer you wait, the more the scar tissue reforms and you're starting from scratch again. The only contraindication listed by the ASG is an acute or incompletely healed perforation for a dilation. Is there a target size to get to? The answer is yes, at least based on this one study. Trying to get patients to about 15 millimeters as a goal will allow most people to tolerate food in a regular fashion. Is there a benefit to going above 15 millimeters? Another study suggests yes, but the price you're going to pay is a higher risk of perforation. What is the efficacy of dilations? Looking at the case series that are available, ranging from about 25 to 45 patients, including a series by our own Dr. Kozerik many years ago, the rate of symptom-free is about 60 to 80% at 1 to 3 years on follow-up. What are the factors associated with failure of balloon dilation? Long strictures such as this one versus a nice short stricture which I caused by doing a large EMR would respond very nicely to a balloon dilation. Extrinsic strictures, no matter where you're dealing with them in the gut, do poorly because the disease is outside the bowel. Trying to stretch chronic pancreatitis, trying to stretch adhesions usually does not work. The rapid recurrence of symptoms is a warning sign that you may be dealing with something ominous, as suggested in the study where all 4 patients with a rapid obstruction ended up having a duodenal cancer. And the need for multiple dilations will tell you, oh, you're doing this again and again. Scratch your head, do you need to do something differently? There's a lack of prospective comparative studies between dilation and surgery, dilation and stenting. There's one cost analysis, again, done over here between balloon dilation and vagotomy and pyloroplasty. The difference in cost was 1/10 between endoscopy and surgery. But as Scott alluded to, really vagotomy is not a surgery done anymore. The adverse events with dilation, oh, they do exist. About a 2 to 3% risk of perforation, which was traditionally managed with surgery, but there are lots of endoscopic ways to fix the OOs that you create. There's a risk of bleeding as well. This is what a perforated ulcer looks like endoscopically. You don't always want to see it, but you can fix it endoscopically. This is a clip closure, and this is what the site looks like 8 weeks later. This was actually a video we published recently of a duodenal perforation. Let me show you how it happened. This was a double duct sign with a duodenal stricture for 2 years. We did an echo endoscopy. It was worrisome for something in the distal bile duct, so we tried to do an ERCP with a balloon dilation to get through. But this is what happened, about a 2.5 to 3 centimeter perforation in the duodenum. You don't always want to see this, but you have to get used to doing this if you're doing complex stuff. And you pass an upper endoscope down and try and figure out what the anatomy over here is. This is the lumen of the duodenum, which you can gently pass the scope through to see, okay, I know my anatomy now. Now how do we fix this? This is a suturing device being put on the up end of the scope. And then endoscopic suturing was used in this case because it was a little too large to get into the mouth of an over-the-scope clip, which is one of the most common ways we close perforations. So the sutures go back and forth, and then sometimes it's hard to grab the opposite wall, so you have all these little nifty devices you can use to grab the wall of the duodenum or the stomach, whatever you're trying to stitch, pull it into the scope and take some nice full thickness bites. There are different ways to stitch. You can do running sutures. In this case, it was so difficult with the anatomy and the position that I had to use a total of 3 stitches. And this is what it looks like when it's done. This is the suture line over here. And then the endoscope is gently passed through to make sure I didn't occlude the duodenum completely. And then for completion's sake, you want to make sure it's tight. And so we inject contrast, make sure there's no leak. And this patient actually did quite well. This is another interesting complication you can encounter. This was a large pyloric polyp. actually an antral polyp prolapsing through the pylorus. This is the rim of the pylorus causing obstruction. This gentleman was not a surgical candidate. He was about 400 pounds, had congestive heart failure. The surgeon said, thanks, but no thanks. And so we did an echoendoscopy to figure out where this lump was coming from, and it was coming from the submucosa. So I said, I think I can take this out. So a snare goes around the lesion, we grab it, and we start to cut. Now, anytime it takes a while to cut, any endoscopist knows there may be something going on, but you're committed at that point, and this is what's going on. By the time we were done cutting, the antrum filled up with blood in about 5 seconds. But if you're patient enough and you're careful enough, you can find the site of the bleeding, which was a vessel in this case, and then a large over-the-scope clip was deployed to stop the bleeding. And you can see what happened. I transected the polyp, and it was still dangling by a little bit over here. Now you want to try and get that out and give the pathologist an entire specimen, so you can cut this off and still take the whole thing off and give it to the pathologist. And this turned out to be a benign subepithelial tumor. Patient did well after a day of stay in the hospital, and this is what it looked like 6 months ago. It's completely resolved. Pylorus is nice and patent. So what's the approach to dilation? It's a multidisciplinary approach. Go slow and reassess clinically. Don't make your decision just on a specific size. See how the patient is doing. Are there adjunctive treatments? Yes. The role for intralesional steroids in the stomach and gastric outlet obstruction is extraordinarily limited based on just these 2 case series. The data is extrapolated from esophageal strictures, where even there the efficacy is questionable. Mitomycin has been studied, more in the esophagus again than the stomach, and it seems to have a role in mitigating risk of recurrent strictures. Let's go on to stenting now. So malignant gastric outlet obstruction is really where duodenal stenting evolved, and this is what the most commonly used stent looks like. It's an uncovered stent. We do not have fully covered stents. So once you place a duodenal or a gastric stent, it is a permanent thing. The patient is either living with this for the rest of its life, or the surgeons have to cut it out. In benign gastric outlet obstruction, therefore, you cannot place uncovered stents, but we have modified other stents. We've always been good at being creative as to what else can we use in this situation. You can use fully covered esophageal stents. You can use 10 millimeter biliary stents. But then you can also use this other wonderful stent called a lumen opposing stent that looks like a dumbbell. And this was the first US case series that we put together with University of North Carolina, where we had 25 patients with GI strictures. And this is what it looks like. This is a gastrojejunal anastomotic stricture, about 3-4 millimeters in diameter. You can see contrast injected over here. Place a guide wire, deploy this stent, and this is what the stent looks like on fluoroscopy. There's a big dumbbell on either side which keeps the stent in place. So the biggest challenge with fully covered stents, which was migration, seems to be solved by this particular type of stent. And so these were the 2 groups of patients with gastric outlet obstruction I've highlighted. There's a response rate of about 60%, and the reason all of these patients had failed multiple dilations before, so you know you're dealing with refractory strictures, and the follow-up was about a year. So this was the point that Scott brought up, a patient he wants me to do this procedure on. What can you do when you have benign gastric outlet obstruction, let's say after a Whipple? You can temporarily treat them with fully covered stents, and so we put this case series about 5 years ago. This was a very nice case where there was a very bad dehiscence after a Whipple operation, a large abscess, and this is what the endoscopy looks like, a complete necrotic breakdown of the gastrojejunostomy. You can see the drain, but where's the afferent and efferent limb? And there it is. So if you carefully push through this necrosis, you can find the limbs and you can see the extent of necrosis over here. This is not the time to stent the patient. So we came out, we placed an NG tube, patient keeps vomiting. So you go back in, and this is what you see. The percutaneous drain, which was supposed to be in the abscess, has migrated into the stomach. It's over here. And so what did we? We converted this into a venting gastrostomy. So we said, let's just decompress the stomach through this drain. But still, patient's doing poorly and the stomach is markedly distended. And here's the problem. The gastrostomy tube is starting to bury in that tract. No problem. We can pull this out and then see actually where the problem is, which is right over here. This is what the gastrojejunostomy has been reduced down to, a 2 millimeter opening. So you can find the afferent limb and efferent limb, dilate gently, and now it's time to try and stent this. So this is how you can put in 2 covered stents. So we used a biliary stent and an esophageal stent, which are fully covered and removable, but you don't want them to migrate, so you stitch them together. And in the early days, we were even stitching them to the gastrostomy. So this is a little nifty way to try and figure out how do you hold these stents in place so they don't slip. And we're just passing a suture through the stent, pulling it out through the stent, passing it back through the feeding tube to secure it to the outside and telling the nurses, please don't cut this suture. And so these stents stay in place. This is the contrast showing you now the limbs are patent. You come back in about 6 to 8 weeks and it's nice and open. So this is what Scott's hoping I'm going to do for his patient later this morning, I think. So malignant gastric outlet obstruction, which is where stents are predominantly used, technical success is extraordinarily high. It's over 90%. That means it's really easy for us to place these stents, but the clinical success is about 80% or so. And this is the reason what Scott mentioned is post-malignancy gastroparesis. A systematic review comparing duodenal stents with gastrojejunostomy, surgical gastrojejunostomy, showed no statistically significant difference in efficacy or complications. As expected, a much shorter hospital stay with stents, but a lot more reinterventions if these patients are going to live longer with stents. This is what a gastric outlet obstruction from pancreatic cancer looks like. You pass a guide wire down. It's fairly straightforward. You deploy an uncovered duodenal stent. This is what the inside of the stent looks like, and this is on fluoroscopy. Are there problems with stenting or pitfalls of duodenal stent? The answer is absolutely. And the main one is luminal obstruction, which can happen usually on average about 2.5 months from tissue or tumor ingrowth. There are other things that can be associated with duodenal stents, and one of them is just failure off the bat, where the stent fails to expand and open up and relieve the symptoms. Patients have to be on a low residue diet. There's often pain associated with stents because of the pressure on the tumor, and anecdotally increased risk of biliary obstruction, which then made us think, can we do something different? Can we pretend to be surgeons and do bypasses just like them? And so about 5 years ago, we started doing this, but the evolution goes back a long, long time, where people were experimenting with button gastrojejunostomies endoscopically in the 1990s. Through the 2000s, they figured out how to poke the jejunum with EUS. And it's only after this lumen-opposing stent came about that we started doing this endoscopically in the 2015-16 time. This is what necropsy looks like at 14 days out in a pig study. There's a nice serosa to serosal adhesion. So I'll just start with this video of the first way we were doing this, which was what we decided to put together a series of these cases of endoscopic gastrojejunostomy. This is a long, ugly stricture in the duodenum. A balloon catheter would get passed down into the duodenum, and then we would look for that somewhere around here with EUS. This is the balloon. We say, aha, we see it. Now let's puncture it. Then we pass a guide wire down into the jejunum, and this was in the days when we did not have a cautery-enhanced stent. We'd have to dilate, put in the stent, pull it back and do it under X-ray and deploy it. So this was the first way we did gastrojejunostomies. And we came up with other little tricks and devices with a rendezvous method where we were trapping the wire, holding it out through the mouth. And then this was actually a nice cute little way. We can see this video. We're doing okay on time. Where instead of going through the stomach to the jejunum, you can actually go from the duodenum into the stomach, where this stent was being deployed from the duodenum into the stomach. You can see the stent open here in the stomach, and endoscopically you'll see it being pulled back with another endoscope. You pull it snug against the stomach, and then you release it on the duodenal side, creating the anastomosis, or a gastroduodenostomy in this case. I'll just show you for fun's sake the other creative ways to do this. This was a colleague and friend in Japan who has a little nifty balloon that he passes down. Let me just show you the balloon. He inflates 2 balloons and traps a segment of the bowel. And then with his echo endoscope, with that trapped jejunum, he can create this anastomosis. But again, requires multiple steps to do this, which is why over the last 30 or 35 cases, we've mostly evolved to this direct method, which is very quick now in about 20 minutes. You fill the jejunum with methylene blue, and contrast, you puncture it with a needle to make sure you're not drawing up, that you get methylene blue up over there. And then you can go ahead and create the anastomosis with a single puncture, deploy the stent over here in the jejunum, pull it back snug against the stomach, and this flow of methylene blue tells you you've created an anastomosis to the jejunum, which you can see downstream over here. Lots and lots of case series since this came about in 2015. But let's go to the comparative studies. These are retrospective, but between the gold standard, which used to be endoscopic stenting, to endoscopic gastroenterostomy. And about 30 and 20 patients, as expected, the recurrence rate of gastric outlet obstruction dramatically lower when you're doing a gastric bypass with an endoscopy rather than a stent. And in this one study, as expected, a much higher clinical response right off the bat as well, as we talked about, because some stents will fail to just open up and relieve that obstruction. It's also been compared to surgical gastrojejunostomy, two retrospective series, 25 and 30 patients. As expected, technical success will be lower with endoscopic gastrojejunostomies because the surgeons are there. I hope they can find the jejunum and bring it up to the stomach and sew it together. So the technical success is lower with endoscopic gastroenterostomies. The adverse events, surprisingly, are much lower when you do this endoscopically than surgically. And in this one study, the cost analysis, as you would expect, endoscopy is much cheaper to do. Patients tend to go home much faster. The other two advantages that I see to endoscopic gastroenterostomy is resumption of chemotherapy, where I let them resume chemotherapy within a couple of days. And there's really no albumin value at which you cannot do a gastroenterostomy or a gastrojejunostomy endoscopically. This is just a picture of a failed duodenal stent 2 days after it was deployed, and we had to rescue it with a gastroenterostomy. So there has been now a systematic review and a meta-analysis of endoscopic gastrojejunostomies of about 12 studies. This is the forest plot for technical success is well over 90%. Clinical success also around 90%. That means about 90% seem to get resolution and resumption of oral intake. Adverse events are low, about 15 to 16% in these 12 studies. Reintervention rate is also less than 10%. Has it been used in benign disease? Yes, plenty of times. We contributed to the series of 26 patients as well. Only 3 adverse events in these patients. And this was, again, an early experience with a few misdeployed stents. Scott mentioned doing a double bypass when you're in there surgically if a patient is unresectable. But if you know off the bat they are unresectable, you can do an endoscopic double bypass. And so we put a series together with Johns Hopkins, 7 patients, where we did a choledochal duodenostomy with a lumen-opposing stent, pulled back into the stomach, and did a gastrojejunostomy. And so in one endoscopic session, we had tissue diagnosis, we had a metastases to the liver, and we did a double bypass at the same time. We then published our experience with long-term outcomes with gastroenterostomy, and this is about 60 patients where the minimum follow-up was 6 months, again with our colleagues at Hopkins. And we had a relook endoscopy in only 15% of patients, and most of these, the stents were open. They were struggling with gastroparesis. 2 patients did have B-zores. They were eating too much vegetable matter. And I very rarely say there's something like too much vegetable matter in your diet. If you cannot do a gastrojejunostomy, do you have an option? And the answer is yes, you can start looking for windows elsewhere. And in this case series of about 5 patients, we found windows between the duodenum and jejunum. And here we are creating a duodenojejunostomy, which allowed this patient to eat food for another 8 weeks before she died from her cancer. So are we there yet with regards to endoscopic gastrojejunostomies? The answer is, I think we're there. We've started our comparisons, albeit retrospective. What we really do need now is some good prospective studies comparing this with surgery and with the different techniques we have. There remains a limitation with gastrojejunostomy, and that is pushing the jejunum or the duodenum away and then seeing this beautiful fat. You try to not want to see fat when you're doing endoscopies, but even when this happens, majority of the times this is fixable endoscopically. The main thing that has given us pause when we are doing gut-to-gut anastomoses or gastrojejunostomies has been the presence of ascites. This warns the surgeons as well. This is a no-no. Try not to get into the peritoneum in any way, shape, or form. However, that being said, sometimes you run out of options or patients run out of options. And we again published a case series of about 5 patients that ran out of all options. And this was a patient with a bad afferent limb syndrome with malignant ascites, had failed 3 double balloon ERCPs, 3 of them at Virginia Mason. And so we decided to say, fine, we will palliate this a different way. And so what you're seeing on ultrasound is a big distended afferent limb with a large amount of ascites still left despite a 4-liter paracentesis. And so you can pass a 19-gauge needle into the ascites, suction it out, and now get rid of any intervening ascites before you create an anastomosis. In this case, I put in a needle just to make sure we're seeing the right afferent limb, which we were. And this is, again, a simple gastrojejunostomy being created to the afferent limb to decompress an afferent limb syndrome. And this patient lived for 8 weeks. Now, you have to take meticulous care of this ascites after you've done this to make sure it doesn't recur and that stent doesn't separate out and the patient's not going to develop peritonitis. So I think with that, I want to stop by just thanking a whole host of people. My department to start. You can see Rajesh and Joanna having joined us, so well photoshopped into this picture. Our surgeons who support me doing some of these things which are non-conventional to start but are slowly becoming accepted as things we do. Our radiologists who are constantly knocking on our doors asking us if we have any ideas, and Bert shows up twice in this picture. Of course, our nurses who are completely, utterly supportive, patient, I wouldn't say happy to work till 8 o'clock sometimes, but still there with a smile on their face doing whatever they can to help our patients. And of course, all the people I get to collaborate with around the world and publish with. So thank you. I think I left some time for questions, yeah?
Yes, and at this time, I want to remind the virtual audience that you can click on the speech bubble on the bottom right corner of your screen and submit your questions, and we'll give you a minute to start sending those in.
Are there any here right now?
Nothing right now.
We have a question in the room.
I have a question. You might want to repeat it for the audience, but are your individual, so the comparisons that would look like about 90% success rate, how are we individually at Virginia Mason? Are we right at that number? Are we better or worse in between?
I think our technical success is a lot higher than that study with 87% for gastrojejunostomies. I keep a track of the ones that I fail as well, and I think we're at about 5% failure rate. So our technical success with gastrojejunostomies is about 95%. The main reason is if the duodenum or the jejunum isn't in close proximity to the stomach, you do not want to create an anastomosis. These are all learning curves I've gone through. The only patient that went to the operating room, Scott and I shared, I pushed my luck a little bit with how far the duodenum was and created an anastomosis, and then overnight the patient leaked and Scott had to go in and operate and help this gentleman. So there's a learning curve to this, to when to intervene, when not to. Our technical success is 95%. The reported rate of peritoneal carcinomatosis staying in the hospital, 50%, is a very old study. They do miserably overall, but I would say majority of our patients actually get to go home after we relieve the obstructions. So I think we do a little bit better than the studies suggest.
A good share of the world's literature was generated here.
Any questions yet?
No questions.
So I want to make one comment. It's amazing. So that case was early in your, I think that was the second or the third case. I just happened to be on call that night. And this is, again, illustrates the importance of communication and stuff. So the minute that patient wasn't doing well, I was called and I said, he did what? I'd never seen or heard of this approach, so the patient required a laparotomy because he had early peritonitis, and I closed the hole, and that guy actually did quite well, lived for another couple years. But subsequently, all of us surgeons have operated on patients that have had these stents. Again, they can be long-term, but they can also be quite useful in the short term. So a patient has an obstruction from an advanced cancer, they get bypassed this way. They literally go home. I mean, they start them on a diet within 24 to 48 hours. They go home within a couple days and they start their chemotherapy. The amazing thing to me is when I've operated on these patients and you go and you look, first you can't find the anastomosis. It's so clean, and the peritoneum up against it, it's just sealed. There's no contamination, there's no abscess, there's no staining in the area. It's as good as a surgical anastomosis because of these alumina opposing stents. And I didn't show this data, but just to illustrate the impact that advanced cancer has on GI physiology. So up to about 8 years ago, shortly after I came here, all this stuff was starting to go on here. And so I was really curious how the outcomes differ from endoscopic bypass or stenting versus an open surgery. So open surgery before this evolution of this endoscope was the only thing we had to offer these patients. And so there's quite a few patients. Over a 10-year period, this was in Bill Traverso's time, most of these operations were done by Bill, Tom Beal, and John Ryan. There were over 50 patients that had a surgical bypass. They were operated on, so these were fit patients. They went in to do a Whipple, and they found that the patient was unresectable for one reason or another. And they had a simple gastrojejunostomy. The median length of stay is 8 days. The average length of stay was 8 days in these patients. And some are in the hospital for 2 months. And so a very simple, very quick operation, it's not the operation, it's the cancer that dictates how soon their bowel function returns. Even though they look fit, when you have unresectable cancer, they don't do well post-operatively. And these randomized trials now that are going on, I can't remember the one that just got published in the Netherlands, in the short term, the stents just blow surgery out of the water with respect to cost efficacy. But if that patient lives longer than 3 or 4 months, then surgery does better because they need less interventions. And so that's where upfront decision making is so important. If you think there's somebody that's going to live 6 months, 7 months because they're going to benefit from chemo, then a surgical bypass makes more sense.
And I've received a few questions. The first is, how often does technical success result in clinical success? And then the second question is, what is the selection process of potential candidates for these advanced endoscopic procedures?
Well, we have this saying in cancer surgery that biology is king, right? So I would say that the answer to the first question is, how often does technical success equal clinical success? It depends on what the goal is of the therapy. So I would say that for advanced cancer, in which the goal is just palliation, that it's 95%. Technical success leads to the clinical success of what you're trying to achieve. We're trying to get the patient home. We want to let them eat. They don't need a nasogastric tube. We want to relieve nausea and vomiting. That would be a clinical success.
Right.
Right?
So, yeah, I can add to that if you like.
If it's for temporary cause, in other words, we want to, let's say benign disease, we want to just tune the patient up nutritionally for a period of time, then again, the technical success rate in the hands of experts like our group is very high. It's over 95%. So if we can temporize and tune the patient up and improve their resilience going into surgery, then that's going to translate into a better outcome. And if the patient is a candidate for neoadjuvant chemotherapy, that's where the biology takes over. If they can respond to their chemotherapy, then we have excellent clinical success of eventually operating on these patients. So it's really, you have to define the condition and the goal.
Yeah, I think that it's always a good question, and you want to let patients know just because you relieve the mechanical obstruction, that means you were technically successful with your procedure, doesn't mean there's a 100% chance you're going to clinically get better and resume everything you're eating. So clinical success, when it's defined by ability to eat at least a soft diet, approaches about 80 to 85% once the procedure has gone great and you were successful with what you wanted to do with the endoscope. So there's still about 15% of people, and you let everyone know you do not know which of those patients you do a procedure on who are going to succeed clinically. That means I may say the procedure went great, but now let's make sure you can eat. So that failure rate is still about 15% if that's what people are trying to ask here.
Thank you. The next question from Dr. Koenneke. When we define success of stents versus surgery, those metrics are usually short-term, and we see data showing more re-intervention with stents versus surgery. If our patients are living median 3 months, are we using the correct outcomes to compare these two interventions?
You wanna
The retrospective study I just showed that came from Tel Aviv basically shows that patients do terrible with surgery when they have advanced cancer. And what I showed for malnourished patients, patients over 75, they live 100 days. Those patients should be stented. There's a randomized trial, I can't remember the Dutch randomized trial study that compares endoscopic stenting versus surgery. And again, the break point is around 3 months, as Dr. Kinnicky says. So if you have a patient with a good performance status, well, this has been shown in the sub-analysis of those groups. If the patient had a performance status that allowed them to get chemotherapy, there was a probability that they were more likely than not to live beyond 3 months. So if their tumor burden is such and their performance status is good enough that they can be treated, then that's kind of where this reintervention rate kicks in. They're going to live longer, all of a sudden they live 6 months or whatever, then they have a need for more interventions. And I'll let Shayan ask this, but I think today their preference is, in those patients, do a GJ endoscopically, because they do great, and they can eat and get them out of the hospital, and they can start their chemotherapy literally within a week. So if you think that the patient's going to live longer than 3 months, I think you'd probably argue for a endoscopic GJ so they can get onto their chemotherapy. If we do an operative GJ, they're not going to start their chemotherapy for 6 weeks. Okay, they need to recover from surgery. Would you agree with that?
And that applies to benign disease as well, where if you think whatever the comorbidity is, they're not going to live for more than 2 or 3 years, which is what I'm kind of seeing now with having done this for 5 years. These stents are staying open for 2 and 3 years out. We endoscope these patients for other reasons. The stent is intact without any luminal obstruction, and they're achieving what they needed to achieve. The problem is most of these patients end up dying from other diseases. And so the place where I would pause and say, look, we really need to still think about surgery is a completely benign cause where you expect the patient to live 5+ years. They should be still handled with surgery, where that is the definitive operation. There's no issue, there's no lack of knowledge about how long these stents will last. Now, when we've been doing this 10 years out and we have enough patients that have lived 10 years with these stents, we'll rediscuss.
And one other thing I want to add, because Shayan did not show this study that was done here by one of our visiting scholars, Dr. O, who worked with Dr. Kozarek, who reviewed all the endoscopic stenting for cancer patients over a recent 10-year period or something like that. There were about 160 patients that were reviewed, and what he hypothesized was, what he wanted to investigate was, how do the patients with outlet obstruction from pancreas cancer compared to other cancers? And the value behind that analysis is that other cancers, duodenal cancer, colon cancer, etc., there's more effective chemotherapy, whereas in pancreatic cancer, this was in the multi-drug era, we know that there's less effective therapy. And so, in fact, those patients that have gastric outlet obstruction from pancreatic cancer, that is a harbinger of short-term death. The majority of those patients, the median survival was 2.9 months if they had pancreatic cancer. If they had gastric outlet obstruction from other cancers, they lived 6 months. So there was a huge difference in the outcome just with the type of cancer they had, which is probably related to their ability to respond, and pancreatic cancer being very aggressive. So I think we would argue, because their survival is so poor, that an endoscopic approach is the way to go if you present with obstruction from pancreatic cancer.
Okay, thank you. A question from the dietitians. Considering the kitchen doesn't have a low residue diet selection, would a low fiber diet be comparable?
No. The answer, very short, is no. And the reason is, when you endoscope a patient that is been on a low fiber diet, where you can say you can have soft canned fruit or soft overcooked vegetables, The endoscope cannot tell you whether there was a raw broccoli in the stomach 2 days later or a soft overcooked broccoli in the stomach. It's the size of the fiber particles. I think compromising the low residue and low fiber, when you really cut out fiber from someone's diet, you're telling them to stop eating vegetables and fruit, which are the essence of keeping us healthy. And so those need to go into a smoothie or a puree, and you need to eat vegetables every day. So I don't think there's an exception to that rule. You get a blender. I'm sure there are enough ways to make smoothies in the kitchen, so if we can work with our kitchen to figure out vegetable and fruit smoothies for these patients, that'd be lovely.
What about a strainer? Should it?
It doesn't have to be strained. The particle size needs to be about 2 to 4 millimeters, so it does not have to be strained at all. This will travel through the stent just fine, and that's actually 2 millimeters is what food gets ground down to leave the stomach through the pylorus, except large vegetables which stay as big pieces, and there's a different kind of wave that sweeps the stomach. So those bigger particles will get stuck in the stent. Not in a gastrojejunostomy, but a duodenal stent.
Thank you. And I'll just leave you with a comment from Dr. John Ryan, heroic. Thank you very much.